Hi, this is Javier Martin Broto, medical oncologist working in the University Hospital Virgen del Rocío in Seville, Spain. It's my pleasure to share this presentation in the context of the Desmoid Tumor Research Foundation. My topic is the Taxanes in Desmoid tumors. This is my disclosure information. So, talking about the rationale of desmoid tumors with anti-angiogenics, it has been demonstrated in preclinical models that beta-catenin enhances HIF-1 alpha transcription. And interestingly, it is also observed that overexpression of HIF-1 alpha induced beta-catenin nuclear translocation. On the other side, Wnt activation is related with metabolic remodeling and accentuates the Warburg effects, and the increase of lactate production and HIF-1 alpha stimulates both neoangiogenesis. Talking about the rationale for taxanes, there is a plethora of publications reporting anti-angiogenic activity of taxanes in the last 2 decades. Anti-angiogenic activity of paclitaxel involving the endothelial cell chemotaxics and maybe invasiveness is seen at lower concentration than cytotoxic activity, which involved endothelial cell proliferation. At lower dose, paclitaxel decreased beta TGF and VEF dependent neovascularization in the cornea by 45% and 37% respectively. And there is a substantial evidence of downregulation of VEGF in vivo, and also in patients, the paclitaxel decreases VEGF plasma level, among other activities as anti-angiogenics. So we designed the HAZE39, we called ABRAVES, to this trial. This is a phase 2 trial of nab-paclitaxel for the treatment of desmoid tumors and multiple relapse refractory desmoplastic small round cell tumors and Ewing sarcoma. We will focus, obviously, today in the cohort of these tumors. So, taxanes downregulates HIF-1 alpha via effects on microtubules. Zinc alkaloids plus methotrexate is the most frequent scheme used in desmoid tumors. And this scheme usually requires a long-term administration, and the toxicity is not precisely mild after, for instance, 6 months. Bone marrow claudication or peripheral neuropathy or pneumonitis are among the potential toxicity with this scheme. And so we plan a short-term administration of 3 months of nab-paclitaxel, 3 weeks on and 1 week off for this phase 2 trial in desmoid tumors. Maybe the advantage is the short time, and then to avoid high frequentation of the patients to the hospitals. So the methods of this trial are reflected in this slide. We enrolled symptomatic and or radiologic progressing desmoid tumor patients, and nab-paclitaxel was done at usual doses for older than 21 years of age, and the double dose for younger of this age. And the main objective was to determine the overall response rate according to REFIS 1.1 and or the worst pain improvement of at least 2 points in the brief pain inventory short form. The MRI was done at baseline and 3, 6, 9, and 12 months from them. And the statistical assumptions were as follows. The null hypothesis was 20%, while the alternative hypothesis was 40%, with these alpha and beta errors. So the first and second stage were 21 and 14 patients, respectively. There was a compulsory central pathology and radiological review for this trial. So some inclusion and exclusion criteria. According to inclusion criteria, age older than 6 months, pathology confirmed desmoid tumors of limbs, trunk wall, head and neck, or intra-abdominal. It harbors beta-catenin mutation. Patients must be symptomatic or in refuse progression in the last 6 months. And actually, the symptomatic, the pain was also in progression, usually. One previous line of chemotherapy was allowed if this consisted in methotrexate plus zinc alkaloids, but previous hormone therapy or prostaglandin inhibitors were also allowed. The COG-1 or 1, and the patients had to have the refuse measurable disease, and also the availability of paraffin-embedded blocks. Some exclusion criteria: prior taxanes therapy for any indication, or less than 4 weeks elapsed time prior exposure to chemotherapy, or more than one previous chemotherapy line, or inability to undergo MRI, or previously irradiated target lesions if radiation dose exceeded 50 grays, or malignancy with the exception of those requiring only local therapy, or pre-existent neuropathy greater than grade 1. So moving on to the results, for patients were enrolled in 8 hospitals from May 2017 to September 2019. The total number of accurate patients in this cohort was 40 patients. 26 were female and 14 male. The median age was 38. And the distribution of tumor sites was as follows: limbs 14 patients, trunk wall 13 patients, and abdominal cavity 7 patients, and head and neck tumor site 6 patients. The reasons for inclusions were refuse progression in 32.5%, symptomatic progression in 30%, or both in 37.5%. Regarding the toxicity, nab-paclitaxel is a well-known drug, and toxicity was not different than already published, and only grade 3 toxicity was seen in one case of mucositis and 2 cases of neutrophil count decrease. Otherwise, the most frequent toxicity was fatigue and also alopecia. Moving on, the main objective results, we have reported an overall response rate according to central review of 20.5% in 8 patients, considering the 39 evaluable patients. If we are considering only those that in the actual, the reason was refuse progression, then the percentage increased to 28.6%. And according to worst pain decrease at least 2 points, this was seen in the 80% of patients, considering all the patients. But if we are considering those included by worst pain improvement, then 100% obtain these 2 points, at least 2 points of improvement in the pain decrease. The median worst pain at baseline was 6.5, while in the end of therapy was 2, and the median reduction was 4 points. The median of follow-up was 18 months, and there were 2 radiological progressions, 6 symptomatic progressions, and 2 both progressions. Head and neck and proximal upper extremity sites had worse 18-month PFS rate, 24% versus 86% in other locations. Interestingly, all but one patient caused an allergic reaction completed the therapy. That means 97.5% of patients completed the 3 months schedule of chemotherapy. Some examples of RECIST response in this intra-abdominal beta-catenin mutated tumor with a shrinkage from 40 millimeters to 16 millimeters, and in this shoulder from 60 millimeters to 37 millimeters. Usually the decrease is seen from the first evaluation, but usually the maximum reduction is in the second evaluation, or in other words, at 6 months after the inclusion. So the remarks of this trial is the short-term regimen with nab-paclitaxel was safe and active in desmoid tumors, with 80% of patients having clinical improvement and 20.5% of patients achieving a radiological response according to central review. Desmoid tumors in neck or proximal upper extremity, maybe this regimen was related with less efficacy in terms of 18-month PFS rate. It should be taken into account as well. We are performing now the correlative analysis, the translational research associated to this trial. Thank you very much for your attention.